workshops, reading of literature that is available, and also acquaint oneself with using the armamentarium for the same in all possible clinical applications that are recommended. Quite naturally, this is not possible unless you have that kind of interest to do the same, which is quite well reflected among all the participants, my good friends here, who have turned up in pretty good numbers on an early Sunday morning to attend this topic. So, one common thing about endodontics that I would like to say is that if you want to do good endodontics, all you need is perseverance, patience, and passion. Why would I say that? Because to sum it up, root canal treatment is a sequence of procedures which are performed step by step in a specific pattern where you cannot bypass any of the steps, neither can you cut short any of the steps. And all the steps are backed with great scientific literature, research, and you have predetermined, preset protocols to achieve the same. So if you were to follow all of them, definitely you can achieve predictable endodontics every time you go for it, at least. And this requires great perseverance till you learn the skills, and even after, when you face different clinical challenges, a lot of patience, and which means that you have to have passion for the subject. Whenever I enter my clinic, I always start with these thoughts in my mind, which I would like to share with you. A dental professional person has no right to be other than a continuous student, as said by Dr. G.V. Black. Be a constant learner. Know your limits. That is, ethics is knowing the difference between what you have a right to do and what is right to do. Very, very important in clinical practice because you're working all by yourselves in your own zone with nobody watching. And above all, the Hippocratic oath, which remains the golden rule of healthcare. First of all, do no harm. If you have the right attitude of constant learning, if you know your limits, and if you take care of your patients by making sure that you have no intentions of doing any further harm, you're already on the right path. Yes. So what exactly is root canal treatment? As a healthcare worker, we always look at the disease we are dealing with. And our endodontic disease is a biofilm mediated infection. And we focus on elimination of biofilm bacteria from the root canal systems, which remain to be the primary focus in management of endodontic disease. The endodontic environment is pretty challenging to remove or eliminate the surface adherent biofilm bacteria. It's not so easy. Advanced antimicrobial strategies are required for optimal disinfection of the previously infected root canal system, which means it is crucial to predictably perform conventional root canal treatments. Such is the importance for achieving success. There are certain objectives and principles which are ageless, which are timeless. One of them being Dr. Schilder's mechanical objectives. Whichever era you belong to, the principles remain the same. That is, develop a continuously tapering conical form in the root canal preparation, make the canal narrower apically with the narrowest cross-sectional diameter across the terminus, make the preparation in multiple planes and never transport the foramen, and keep the foramen as small as practical. So the biological objectives, that is what we have to achieve, is completely debride your pulp space from the pulp tissue and the necrotic debris. Confine your instrumentation to within the root canal space and do not force the necrotic debris beyond the foramen, and creation of sufficient space to place your intracanal medicaments. Now, healing following endodontic therapy usually occurs if you make an appropriate, accurate diagnosis, select your case aptly, and use a skilled technique and equipment for performing the treatment. Ensured healing is possible. How do you take the decision to perform root canal? As always, a proper case history, both medical as well as dental history, careful examination of the clinical condition, and preparing an accurate diagnosis based on thorough evaluation of your radiograph, intraoral periapical radiograph, which has been taken appropriately and processed, which is equally important. And if needed, Take another view of the same by tilting your cone either 15 degrees mesially or distally to visualize whatever details you want to take in before making a diagnosis. If you're still not happy, do not hesitate to go in for a CBCT, a cone beam computed tomography, for making an appropriate diagnosis. So what do you look for in the X-rays? First of all, you determine the tooth morphology and ascertain the cause of your dental problem. Second, you decide whether the tooth can be restored after all, and the complexity of the treatment. Now, why I would like to focus on the complexity of the treatment here is that we as clinicians always have a goal. We have a stipulated period of time of practice every day, and we have a certain number of patients coming in, and a certain number of productivity is expected, because after all, we have to pay the staff, we have to pay the bills, isn't it? So whenever you look at a case, especially root canal, which requires a lot of time and patience, you have a couple of things to decide. Certain things like complex cases require us to invest a lot of time in it, and 100% there'll be assured results. But do you have that kind of time? If you have a roaring practice, maybe you do not want to invest that kind of time in that kind of a case. So there is no harm in referring to a person who has invested their entire setup and armamentarium exclusively to dedicate the time towards endodontics. Or you can have a consultant over who can sit on a specific stipulated dental chair just to perform that kind of treatment. So this decision making also requires the clinician to understand thoroughly at the very stage of treatment planning. The complexities which would be visible, like the presence of a pulse stone in a pulse chamber or any other kind of obstructions, maybe a post, a pin, a separated instrument, or even a root canal filling material, could be equally challenging. And presence of variations in anatomy like additional roots or probably excessive curvature in the roots, which could also complicate the procedure. So this decision making is important to know, first of all, how tough the case is, whether it can be brought back to form and function, whether you would want to do it, or whether you would want to allocate somebody else to do it and give that necessary time to complete the procedure. What are the factors that determine success? After all, clinically, we all have one goal, and that is success in the treatment, so that you have happy patients, patients coming back again and again to you to complete their treatment, and also referring you many more patients. So careful case selection. And remember, when you execute the treatment, there should be no shortcuts in any of the steps throughout the treatment procedure. Having the skills necessary and the armamentarium necessary for those specific cases, and making sure that you follow all the endodontic principles. Remember, our battle is with the microbial flora, and at any cost, in any way, it is not possible to completely eliminate the microflora in the root canal system. It can only be brought back to a much lower number, and we can entomb the remaining bacteria in your obturation, ensuring a great apical and coronal seal with either single or multi-visit treatment. And that helps your host immune response to recover and heal the tooth. Another very important thing that I want to focus on is that when you do a root canal, try and do it right the first time. Why so? Now, with advances in root canal treatment, with the available armamentarium, with the available information easily available over social media, YouTube, and everything else, it is possible for any clinician to sum up all the essentials for performing the treatment. Now, what happens is, still we see a lot of failures in root canal treatment. Now, whenever there is a failed case of root canal, there's so many reasons behind it. Above all, it also hints at certain things that probably the operator who performed the treatment did not have the necessary armamentarium or the skills to use the armamentarium, or probably the time to execute the treatment, or probably the necessary knowledge to go about doing the same thing. This could be any beginner, this could be anybody, anywhere. So why put your hands into something which gives you so much of trouble? So remember that whenever you take up a case, try and do it right the first time. Plan the case well. Employ a specialist, or if you are equally skilled to do it well, if you have the passion to invest that kind of time in performing the procedure, go ahead. Make sure that you do it right the first time. because even if it is an uninfected tissue of a vital pulp which is left behind, remember that on degradation, it can create lesions of endodontic origin by production of lytic enzymes and byproducts, which will leach out of the portals of exit. And what happens? It gives rise to a stable endodontic infection with all the bacterial species interdepending on each other, creating a nice environment for them to prosper. Well, that is not what we wanted. No, what you're dealing with, you are dealing with pulp tissue, you're dealing with collagen fibers, ground substance. Now, if the pulp is only superficially infected and the root canal is free of bacteria, then provided your aseptic chain is maintained during intracanal procedures, it is a relatively easier task. But if the pulp is necrotic or associated with periradicular disease, there is ample evidence that the root canal system is infected. In all these cases, the root canal system should ideally be cleaned and shaped and an intracanal medication placed and root canal filled at a second appointment or maybe subsequent appointments. A necrotic pulp. So what do you expect in a canal with necrotic pulp? The content is always dead cells, stagnated tissue fluids, tissue breakdown products, and many of these tissue components will have a cytotoxic effect, and traditionally such breakdown products have been regarded as the main etiological factors for apical periodontitis. It is really tough to thoroughly clean your root canal system when you're dealing with a necrotic pulp because they have already by conventional methods. Is there any contraindication to root canal? As such, there are no virtually systemic contraindications present to endodontic treatment. However, we have to take a case history of their medical problems like heart problems, ailments, any kind of allergy known, or their history of diabetes or infections like hepatitis, HIV, any medications that they could be taking which could interfere with their visits or any kind of treatment that they are undergoing, and also details of their physician's name, address, and phone number, which should be done essentially. Now, what is the principle of endodontic treatment? If you take a closer look, it is a procedure. It is an operative procedure, very similar to a surgical procedure, which requires an aseptic technique and debridement of the wound, drainage, and gentle treatment of the tissues with both instruments and drugs. So how do you provide that kind of aseptic environment when you render root canal treatment? Of course, the rubber dam. The rubber dam is necessary to isolate the operating area in exactly the same way as how a surgical drape is essential for similar invasive medical procedures where bacterial contamination may have a profound effect on the outcome. Believe me that we are all dealing with the patient as a whole. So once we perform the root canal treatment, you also have to attend to bring the tooth back to functionality, which means you have to give the necessary prosthesis, be a crown or any other kind of extra coronal prosthesis. If you have to give that, you have to be assured that this tooth is moving towards healing. And for that, you have to follow all the necessary protocols and especially above all, an aseptic technique, which means learning the art of rubber dam isolation is definitely mandatory for all of us. Anesthesia. Working on a patient who is in pain is a trouble for all of us. And also the time consumed is much more. We lose patience and our productivity on the patients that come thereafter may not be the same. So if you want to be in a good mood, if you want to be very productive when you're at work, you have to learn the art of giving good anesthesia to perform the treatment, so that all the pulp tissue is removed. You can execute the mechanical preparation as well as disinfection procedures with great ease. Rubber dam isolation. If you notice, a rubber dam isolation not only helps you with the aseptic technique, but also gives you great moisture control and a great stable environment to perform the procedure in total focus on the tooth that is concerned. Now, before we actually move ahead with the treatment, you have to prepare the tooth to receive the treatment. Although it may sound strange, because if as I myself am a clinician, and I'm a clinician first and then an endodontist. So I always think about things from a patient point of view and a practical point of view where I have a stipulated period of time to deal with each case because I have the next patient coming over. So whenever we talk about a pre-endodontic buildup or pre-treatment, the first thing that comes up is why at all perform pre-treatment? See, pre-treatment is like a step before you actually go ahead with the next stage of endodontics. That is, it helps you to know whether this tooth has a great prognosis or not. Because in pre-treatment, we perform all those techniques that prepare the tooth for endodontic therapy. and helps us with optimal isolation of the operating field. So before you actually begin your endotherapy, you know a lot about this tooth, whether this tooth is going to respond, whether this tooth can be made functional, whether you can give a great crown or any kind of post-endodontic restorations or not. Why is it important? Because nobody, let us accept it, that no tooth comes to you for root canal which is in great shape. They're badly broken down, they're severely atreated, it has gingival proximal caries which has gone into the gingival interdental papillary area, and you have to salvage the tooth, you have to build that missing wall, and that has to be done. You have to remove the decay, you have to remove the leaking restorations if you want your treatment to be successful. And when you do so, you also come to know what is the final tooth structure which is left behind after all these damages, and then you know whether you can actually bring it to form and function at all. And then you can go ahead with the pre-endodontic buildup. Now, pre-endodontic buildup is nothing but an attempt to bring back the tooth back to its contour and contacts with all the four walls intact, so that you create a fixed reference point for your stoppers for establishing working length throughout, so that you can place the clamp of your rubber dam properly and have a stable isolating field, so that you provide a reservoir for the irrigants to act while you're preparing the root canal. And also it helps you in giving a good temporarization in between appointments. There's so many benefits of performing a pre-endodontic buildup. It is not necessary that you have to perform a pre-endodontic buildup with either a stackable composite or a flowable composite. You can even use simple things like glass ionomer cements. You can go for a copper band. You can go for anything to make a pre-endodontic buildup possible. So this should just ensure that it gives you a stable environment while you're working. Now, if it is impossible to have a wall which stays in between appointments, you can even have a liquid dam placed as a wall, as the missing wall, till you execute the treatment. So you have excellent isolation and moisture control while executing the procedure. So remember that before actually putting your hands into root canal treatment, you have to remove that caries, you have to remove the defective restorations, because you can always give them better restorations post-treatment. You can always give them great quality restorations, post-endodontic restorations, post-treatment. They have to be aware of what kind of quality you're able to give them if they are willing to let you perform all these procedures. Gingivoplasty, gingivectomy whenever necessary, and reinforcement of the remaining tooth structure, obviously with your pre-endodontic buildup. Now, whenever we think of root canal, we have to remember certain anatomic landmarks, because even if you are beginning with the axis, even if you have evaluated your clinical condition of the tooth structure and seen the radiograph, you should know what to look for in the radiograph. And what is important is you have to know that every tooth, be it a molar, premolar, or an anterior, has a crown and a root. The crown houses the pulp chamber after the enamel and dentine, and the orifices are generally located at around the same level as your cemento-dentinal junction, which becomes your reference point. Why so? Because when you perform axis opening, the biggest problem is how much to dig till you get that drop, till you get that feel that you're into the pulp chamber. So that again takes a lot of time. But if you have judged it well by looking at your radiograph, and if you're familiar with the anatomies, you will not have trouble or waste your time while performing this procedure. Secondly, knowing that every pulp chamber has pulp horns. Pulp horns are located at a particular angle and a particular level, and it becomes easy to breach into the pulp chamber through these pulp horns. Knowing that the canal orifices have a specific location, the root canal system extends from the canal orifice right down to the apical terminus. You're sure to find some accessories, laterals. You're sure to encounter an apical delta along with your apical foramen each and every time you work with the root canal. And no two anatomies are ever similar. So these are the things which you have to bear in mind every single time you work on a root canal, be it a central incisor or a third molar. Yes, this is just this radiograph of mine I've just shared because it was a routine premolar. I just followed all the protocols. I did not expect anything great, but you can see clearly in the apical third those multiple portals of exit that have been achieved at the time of obturation. It is simply following all the protocols without missing or bypassing any one of them and having no shortcuts while executing your root canal treatment. You're sure to find great results both in the form of your post-observation radiographs and in the form of healing, like some of the radiographs which I showed you initially. One thing that puts us off is curvature. What we have to remember that a curvature of about 20 degrees in a narrow canal can be tiring, can be impossible to negotiate with endodontic instruments, whereas a curvature of more than 30 may be easily negotiated if the root canal is wide and if the tooth is placed in a much more accessible position to you, like say a premolar or a first molar. Now, it all depends upon your mindset. It also depends upon understanding how much access you have to the tooth. Sometimes if the tooth is tilted distally or mesially, even an ideal tooth with a normal gradual curvature will become a challenging curvature simply because the operator is not able to reach that area conveniently because of the angle at which the tooth is placed. So success in negotiating these curved canals depends upon understanding the degree of curvature, the constriction of the root canal, flexibility of the instruments which you are using, and the skill of the operator. Now, generally, how do we practice? We practice by using extracted teeth. What happens when you practice with extracted teeth is that the tooth is in your left hand and instrument is in your right hand, and you are able to tilt the tooth according to your convenience. So you're not exactly getting the feel of how you would feel in the patient's mouth. In fact, it is much more easier in the patient's mouth because the tooth is stable. It will always remain at the same fixed angle, and the jaw of the patient will always give you that stability which you won't have when you hold it in your left hand. Actually, it is much easier that way. So these variables are always there when you practice, and there is no harm in practicing on extracted teeth. Now, one thing that you have to remember is when you practice on extracted teeth, you come to know many things. You look at a radiograph, you will notice that there is a certain amount of curvature. This is how you would see, okay, there is a curvature, there is a gradual curvature. And you know that the mesobuccal and mesolingual, probably they're meeting somewhere and they have a confluence there onwards. But what you don't see is that whether the canal has a multiplanar curvature or not. This is only possible when you learn how to use your hand files well. Yes, I'm talking about hand files. And I must mention at this point that hand files have a great role to play in modern endodontics as much as they were in previously practiced endodontics. They form the pathway for your rotary endodontics, and you still cannot function altogether without hand files. So these hand files, especially a number 10K file or a number 8K file, when placed into the root canal, which are pre-curved, you can explore the canals. And when you take them out, you can see the multiplanar curvatures. Now, this is a buccolingual radiograph of this tooth. Like always, now the same tooth, I shall take a mesodistal. Can you see? The mesobuccal and mesolingual canals actually have an acute curvature which is not visible in your regular buccolingual radiograph. And see that acute curvature that is present in this canal. It is not at all detected unless you use a K file, negotiate the canal, take out the instrument and see that in your file. So learning how to use your tactile sensation, learning how to use your K files to negotiate and work around your canals is the most important step for successful modern endodontics. Now, this is a case which has a curved canal. When I just have a look at it, obviously it looks like it is curved in one plane, but I think after seeing the previous extracted teeth, you will agree with me that it is definitely not a single plane curvature. There must be a multiplanar curvature. So this is the basic knowledge that you have to have before beginning with access opening. We have given anesthesia, patient is ready, we have done the pre-treatment, we have built up the missing walls and isolated the tooth with a great rubber dam isolation, and now we are ready for access opening. At this juncture, I would like to tell you that most of the times it is better to perform the access opening before rubber dam isolation, simply because when you isolate a single tooth for root canal treatment, you lose the orientation, spatial orientation with the adjacent teeth, and there is a high chance of ending up with cervical perforations. So it is always better to perform the access opening first and then go ahead with the isolation before inserting even a single file into any of the canals and preparing them. So what is this access opening? It is the key to successful cleaning and shaping and three-dimensional obturation of your root canal system. So it is actually the door to the complete process. If done well, you can have great results. An adequately prepared access cavity is crucial for effective instrumentation and delivery of irrigants into the root canal system. Now, what we have to remember is attempting to treat the root canal system without detailed anatomic description would be equivalent of a physician looking for an appendix without having read the Gray's Anatomy. What are the objectives of your access opening? That is simply to locate the root canal system, facilitate an unobstructed access to the root canal system, prepare it, obturate it, and provide a great platform for a definitive coronal restoration for a wonderful coronal seal. How do you achieve it? You have great armamentarium available nowadays. First and foremost, whenever you perform root canal treatment, make sure that you use a front surface mouth mirror. Why? The degree of reflection of the image is near natural when you look through a front surface mouth mirror, because reflection is more than 75%, almost 99%. Imagine the quality, and maintain those mirrors well. Keep them exclusively for these kind of procedures. Work with magnification tools. Use long shank instruments. Use burrs with a long shank. Use burrs which will give you good visibility of the pulp chamber, that is surgical length burrs. Endodontic spoon excavators, DG16 explorers, always for each case. What is this DG16 explorer? You can visit my channel. There's so much in detail given about it. And if you have this, you're sure to find all your canals for sure. Know everything that is present in the pulp chamber just by tactile sensation and working with your explorer. JW17 Micro Explorer is smaller than, the tip of which is smaller than a DG16 Explorer, gives you great results if you have it in locating canals and removing the debris. Ultrasonic tips, which are dedicated for endodontics, because they are great. They can work in a wonderful way where you are not, see what happens when you use rotary instruments, even if it is a micromotor burr, it moves 360 degrees. When it moves 360 degrees, what happens is that it is cutting all the walls that it comes in contact with. That's a lot of loss of tooth structure, because endodontics is a micro procedure. It is not a macro procedure. It's not like extracting a tooth where you're moving your fingers, your elbow, and your hand up till the you're moving your fingers, your wrist, and your elbow. So there's a lot of movement. Whereas when you work in endodontics, you're only using your fingers, and maximum you're using your wrist. May I request you to please take care of the, I think somebody's speaker is on. Can I continue? Yeah, thank you. So the ultrasonic tips, it eliminates the bulky head of the handpiece, which generally obstructs vision. And most of all your preparations, the de-roofing and finishing the walls and everything is happening purely by tactile sensation. But if you use ultrasonic tips, first of all, without water, you can clearly see what you're doing. You'll never go wrong because it only cuts where it comes in contact with. It does not cut 360 degrees. So you're saving a lot of tooth structure. You have a lot of precision and control. So this is what the DG16 does when it locates a canal, and this is your JW Micro 17, which is much more precise and refined. Okay, so the points to remember when you perform access opening: avoid leaving behind remnants of pulp chamber roof together with pulp tissue. Why? Because when you leave it behind, you're actually leaving necrotic tissue behind, which will release toxins, which can be detrimental to your root canal treatment. Walls of the access cavity should not deflect an instrument which is placed in the canal. So even if you're performing ultra conservative access or a conservative access or a micro access, remember it has to be well planned using all the equipments that are available today. It's not a random preparation, and one should not get carried away just by looking at some images, because there is a specific science that is applied to it. There's a certain concept that helps you locate the access opening coinciding with the point of orifice, so that there is no deflection in the instrument when it is placed in the canal. And this requires a lot of skill and experience to execute. Avoid damage to the pulp chamber. Your pulp chamber is like a map which tells you where you are when you're lost in the desert. Because when you have prepared your access opening with your round burr, when you have refined your walls, if you're performing a conventional access, your pulp chamber is located almost 6 to 7 millimeters down from the occlusal surface. So you know nothing about what's happening inside. And the only thing which can help you is the anatomy of the pulp chamber floor. You can see It is very easy to locate canals if you just follow the developmental grooves, which will lead you automatically to the orifices. And it is always easy to locate canals following the floor anatomy and following the Krasner's and Rankau's laws. So the Krasner's and Rankau's laws are a few basic laws which help you in locating the root canal orifices consistently every time. I have forgotten to share the video in my presentation today, but please feel free to visit my channel Upskill Dental Academy on YouTube, where you'll find 2 videos dedicated to locating root canal orifices consistently every time you open an axis. Conserved tooth structure. That is, when you follow the anatomy, there is very little chance for you to cut extra and cause loss or damage of tooth structure. So there is no chance of weakening or fracture, and provide an excellent coronal and apical seal. Remember one thing, axis means destiny in endodontic therapy, and if you try to cheat axis, he will hunt you all the rest of the treatment, in the words of Dr. Buchan. And this is true every single time. Now, there are so many methods which are recommended: axis cavity designs, microconservative, ultra-conservative, conservative, and then you have your traditional conventional axis. Which one to follow? It's pretty exciting. If you have a lot of cases as a clinician, it is your world, it is your zone. You would want to try different axis cavities and see what works best for your patient. But how do you take these decisions? Now, what we have to remember is that the actual size and shape of your axis cavity is determined by the size and shape of the pulp chamber, and quite naturally, it will be smaller in older patients and larger in younger patients. So your pulp chamber morphology is dynamic and variable. So depending upon what kind of a case you have, depending upon thorough radiographic examination, reading your CBCT well, you will plan. And if you have a microscope, there's nothing like it. You can have great conservative axis, or you can stick to your conservative axis or even the traditional axis to achieve fantastic results. Knowing that axis cavity is always determined by the size and shape of the pulp chamber and not anything else. So here is an example. This is a tooth. This is tooth number 48, and there was a mesial proximal caries, and this axis opening has been performed through caries-driven axis. That is, I have just eliminated the caries and I have not done anything else other than deroofing of the pulp chamber to achieve access to all the canals, straight line access to all the canals. Now, this is a few examples that I have here. Now, this is an example for a truss axis. I had opened individual axis cavities for the distal and the mesials, and the truss is clearly visible. This is post-obturation. You can see one conical piece here and one conical piece here, and the truss exists in between. So this was an experiment. I don't do much of micro-axis cavities, but I was just studying the possibility and feasibility. And if you notice, I managed to negotiate and prepare two canals, both distally and mesially. This is a caries-driven axis. This happens in most of the cases. If you understand how to do it, you'll not have any problems. These are conventional axis preparations, and this is a conservative axis. And if you notice, in any of these axis preparations, all the canals have straight line axis. There is no deflection of the instrument when you try to enter into any of the canals, even though they are prepared now. So that tells you that it requires careful planning and understanding of root canal anatomy. So here's an example of what we do when we perform conservative axis. Generally, what happens when you perform an axis opening, then you rush in. Once you feel the drop, you take the next instrument, round burr, and deroof the entire pulp chamber and use your finishing burrs to create a gentle flare. But this is not done in conservative axis. What we do is we try to retain the pulp horns and we just open the axis. So you have a frustum-like structure created in your pulp chamber instead of the regular flare, and you get a tiny little flare in the occlusal surface, like what you can see over here in this axis preparation. You can see that there is an extremely curved canal. The canal has an extreme curvature in the apical third. However, I still have a straight line access to this canal, in spite of not removing the pulp chamber completely, simply because the axis opening was performed by carefully planning so that the point of entry coincides with the point of orifice opening, and hence a straight line axis. So when you tend to save the pulp horns and save the tooth structure that comes associated with that. You're saving a lot of dentine, you're saving a lot of tooth structure, and that kind of is supposed to improve the longevity of the tooth. And what was I talking about? The truss axis. Now imagine the situation where you have a mandibular molar with mesial and distal canals, and you open individual access cavities. So they are kind of small cones here, right and left, and you have a truss in between. So you are kind of saving a lot of tooth structure in between, so that in spite of performing a straight line axis, you can see that these canals have straight line axis. They are not deflecting while being placed into the root canal. So this can also be considered in access opening. However, a lot of studies are being performed to understand the feasibility of performing this kind of access, and still a lot remains to be learned. So automatically your pulp chamber, your access has a frustum-like shape. It's a part of a cone, you see. So there is your frustum. Now, nomenclature. Now, since I spoke about them, you should also know about the different nomenclatures. You know, the traditional access cavity is where you completely remove the pulp chamber roof, and you also achieve straight line access by finishing the walls, creating smoothly divergent axial walls so that all the orifices can be seen within the outline form. What is a conservative access? This is what we learned. Once we have enough experience, we try to perform conservative access opening. We begin from the central fossa of the occlusal surface and extend it smoothly with convergent axial walls, making sure that you do not cut more than what is necessary and preserve that part of the pulp chamber roof and the dentine that comes along with it. An ultra-conservative access cavity is also called as a ninja access. These start out as described in conservative access, but there is no further extension, maintaining as much of pulp chamber roof as possible. So they just get smaller and smaller and much more precise and much more well planned. So in these kind of access cavities, unless there is planning involved, unless there is skill involved, it is very difficult to achieve great results, because I will tell you what are the things that you have to struggle with. Truss cavity is where you preserve the dentinal bridge between two or more small cavities prepared to access the canal orifices in each root of the multi-rooted teeth. The caries-driven access cavity. Now, this is the one that I showed you. Access to the pulp chamber is performed by removing caries and preserving all the remaining tooth structure, including the soffit, which acts like an underside of an architectural feature, like the ceiling and the corner of the ceiling and the wall. So again, you get so much of dentine, just imagine that. Then you have the restorative driven access cavity. So here you have restored teeth. There is no caries, but access to the pulp chamber is performed totally through your restoration, either partially or completely removing it. I would always prefer to completely remove a restoration if present, because you never know from where which part is leaking, and there could be some secondary caries lying there waiting to destroy all your efforts. Coming to the minimal invasive access cavities. Now, what these minimal invasive access cavities have taught us is that the smaller the access cavity, the more difficult it is to visualize and debride the pulp chamber well, to locate, shape, clean, and fill the canals. And there is always that risk of iatrogenic complications as a result of poor visibility. This is more so if you're not working with any magnification tool. If you have magnification tools at your disposal, and if you're experienced and you know to work with them, then you can definitely attempt these cavities only after reading and gathering enough knowledge and information about the same. And yet, it will have an impact on your treatment outcome if you're not well versed with them. Now, why do all these things? Why not just stick to what we were doing? Because the conventional access was giving us wonderful results, wasn't it? So basically, it is all about the pericervical dentine, which was first described by Clark and Khadimi in 2010. It's an area around 4 millimeters coronal to the crest of the bone and 6 millimeters apical to the crestal bone. Now, what happens is this is a critical dentine for tooth strength, and it should be conserved as much as possible and ensure long-term retention of the tooth. It is also the area of the tooth that is destroyed with access burrs, orifice openers like Gates Glidden, orifice shapers, which are a part of your rotary systems. So what happens, the more you thin it out, the more compromised it is, and its structural integrity is seriously affected. Yes. So one thing we have to remember now that we've spoken about it, all these conservative access cavity procedures have to be performed only if you can use 3D imaging technology, have an operating microscope, or at least a pair of loops with high magnification, high illumination, having the necessary endodontic armamentarium, that is your thin ultrasonic tips and a front surface mirror, having good irrigant activation tools and flexible instruments to perform this, because the instrumentation here would require us to use heat treated files which can conform to the canal anatomy without getting affected if they're slightly deflected. Conservative access cavities, truss access and ultra access negatively affected canal transportation and irrigation procedures, and they're not recommended, particularly in teeth with necrotic pulse. Why? I told you right in the beginning, for this very same reason, that when you have necrotic pulse, there's so much of necrotic tissue, there's so much of dead tissue present in all the nooks and corners of the root canal system, that it probably is prudent to have a nice wide access and clean thoroughly every nook and corner of your system, the root canal system. Considering additional research is needed to provide robust and conclusive evidence on these topics, it can be concluded that there is lack of supporting evidence to introduction of these cavities in routine clinical practice unless the clinician is well-read, is well-experienced, has the necessary skills, and constantly follows up with the latest scientific research that is available on these access cavities. Now, this is your guided, guided endodontics. Now, this is supposed to be a reliable alternative when treating teeth with anatomical variations, especially calcifications, and is supposed to be very useful, especially in anteriors. Articles describing guided surgery and guided access cavity preparation are highly accurate techniques when comparing the real cavity to virtual planning. With the help of special software, alignment, as well as using the CBCT and surface scan allows virtual planning of an ideal access cavity. So what happens is in calcified teeth, it's quite natural if you do not have magnification that it's not possible to negotiate the canal without destroying a good amount of tooth structure. Whereas if you follow the guided endodontics, it is possible to achieve the same results with minimum loss of tooth structure in a very well-planned way. So that you get a template which is produced by means of a 3D printer, and this template guides a minimally invasive drill into the calcified root canal. So that's fantastic, considering that it will also save you a lot of time and a lot of effort over this tooth. CBCT, cone beam computed tomography, is an essential tool in almost though all those cases which have variations, which have anatomic variations in the root canal system. Wherever you have doubt, you always have to go for a CBCT. It helps you in determining the orientation, angulation, and morphology of canals. Magnification tools, be it dental loops or the dental operating microscope, make sure that you have one of them or both of them because they are essential for your endodontics. When you are able to visualize better, you can always do better treatment. If you're able to see the pulp floor anatomy, if you're able to negotiate the root canal orifices by having a look at them, if you can see where exactly a calcified canal is located simply because you're working with high magnification, there's nothing like it because you'll work with great precision. And learning how to use these magnification tools will also contribute in a big way towards your ergonomics. It will improve your work efficiency. It will improve the way you can put in hours and hours of work without feeling exhausted and thereby improve your productivity. Magnification, not only that, in endodontics, it helps you identify and detect the canal orifices. It helps you in locating your accessory canals, your hidden canals, any kind of changes in the pulp floor, which is important. Obstructions and pulp calcifications with the use of magnifying loops and microscopes will reduce chances of perforation and other such accidents and make your treatment much more predictable and precise. Coming to, now that you've located the orifices, now you're ready to place your first instrument into the root canal system after completing your rubber dam isolation. Once you've achieved a stable isolation, you will establish the glide path. Now, what is this glide path and what do you have to do? For me, it is one of the most important steps in root canal treatment. It requires a lot of alertness, a lot of patience, and you should dedicate the first few minutes completely towards establishing the glide path because it can break or make your case. Why? Always use a sharp new hand file and work with total focus because you have enhanced tactile sensation. It's very easy for us to lose a few apical to millimeters if you just do it randomly. Because what happens is that even if you lose 1 millimeter of your apical part of the root canal, you're leaving behind millions and millions of microflora, which is not going to allow your tooth to heal. So instead of struggling with, instead of creating a ledge or a transportation or any kind of iatrogenic defect and then struggling to negotiate it, it is better to work with full focus and attention and respect the canal anatomy and negotiate your canals to patency and produce a reproducible glide path every single time you place your instrument in the canal. Now, what exactly is this glide path? In aeronautics, the glide path is the approach path of an aircraft when landing, usually defined by a radar beam. And it is the smooth radicular tunnel from the canal orifice to the physiologic terminus, and it facilitates 3D cleaning and shaping of the root canal system. So that is your glide path. So basically, what I must tell you at this point is that your rotary files are pre-programmed. They only know to perform the function for which they have been designed, but they don't know to find their way. So you have to create the path for them so that they can execute the task for which they have been designed excellently, in an excellent manner. Just quickly have a sip of water before I... Yes. So in endodontics, this glide path is a lack of in endodontics. When you're not able to establish a good glide path, it often leads to problems like ledge formation, transportation of the natural canal anatomy, blockage of the canal with dentinal debris, etc. Now let's have a look at a small video on glide path. This is available on my YouTube channel. So what I basically am trying to convey in this video is about the significance of glide path, as I already mentioned to you, and how to establish this glide path in every single case. So as I already told you, it's a smooth radicular tunnel from the canal orifice to the physiologic terminus, and it helps you in performing every task that comes hereafter. So hence your radicular tunnel, that is your glide path, right from the coronal orifice to the apical terminus is very, very important, right from establishing your working length to restricting your entire treatment to within the root canal system every single time. It requires a lot of patience. Always use well-fitted gloves because you're working with, in a very precise manner, use irrigation, always lubricate your canals so that there is a smooth flow of files. Slight pre-flaring generally helps. If not, if you're not confident, you can just directly pre-curve your file and place it inside the root canal. Slight amount of pre-curving, gradual pre-curve, not an acute curvature, before you place the instrument into the root canal orifice. Gently run it in a watch winding motion. It will slip into the canal and glide into the canal and slide into the canal. If you're not feeling this, if there is an obstruction, be sure that there is some fibrous tissue or denticle or an acute curvature in your root canal anatomy. If you do not, it will straight away reach up to the radiographic terminus or your physiologic terminus. Learn to use short amplitude vertical strokes when you work with your glide path. Once you have established your glide path, make sure that it is super loose number 10 K file so that the K file literally drops into your canal smoothly. Why? Because when it is prepared to this level, it becomes easy for your rotary instruments to literally glide through the path which you've created for them and have lesser problems during rotary instrumentation. So this is just a summary of how you would create your glide path for your rotary instruments. So what is endodontic glide path? I think we can sum it up as a secret to rotary radicular safety. Now, what basically happens is that your rotary instruments are like artificial intelligence. They are pre-programmed to do their function, but they do not know where and how to do it. So you have to create this path using number 10 or number 8 K files. Whenever you have an obstruction, you should change your file, go back with a smaller file, and detect and explore your canals by pre-curving your glide path files. Look for an abrupt curvature, look for a bifurcation, look for multiple portals of exit, because all this is like gathering information about your root canal system while you establish the glide path. The tip of smaller sized files, however, can easily get separated at these bifurcations and can easily go unnoticed unless you detect it on a radiograph. So always go with a brand new number 10K file for glide path establishment. And eventually you will notice that once you learn how to pre-curve it aptly and explore the canal carefully, you will definitely reach the terminus and also explore the canal efficiently. Now, what is the difference between performing endodontic treatment and any other treatment in dentistry? Now, in endodontics, all the movements are micro. They're restricted to the movement of your fingers and maximum the wrist. So when you're running your file into the root canal system, and when you're working in the apical thorns, which is the most crucial part of your root canal system, it is quite likely that the dimension of your vertical strokes would be very small. So here's a video showing how minute and micro the movements are. See the amplitude of vertical strokes when I place my file into the apical third. So I'm placing the file into the apical third. You can see the file slowly progressing. So your file has reached here and now it is going to move into the apical third. Now my strokes in the apical third, when I prepare them, have to be extremely refined. And the movement of my fingers are so minute. Can you make out? The vertical strokes are extremely minute. I'm actually preparing them to dimension of 3 to 4 millimeters. But the strokes are that minute that you cannot even see the movement of my fingers. So if you were to make your movement of your fingers obvious, then probably you're not moving it by 3 to 4 millimeters, you're moving it much more. And that is the reason why you end up with ledge. That is the reason you end up with problems of blockage, debris, etc. in your apical third. And your apical third is the most crucial part of your root canal system, which houses a lot of microflora and has to be dealt with efficiently. If you learn how to deal with the apical third, you have definitely learned a great part of managing your root canal system. So see the dimension of my amplitude of my strokes, they're extremely small. There's hardly any movement involved. So this is the kind of amplitude you have to give when you work at a micro level in your endodontics. What is pre-curving? Pre-curving helps in reducing the restoring forces that are present in your file. The file has a tendency to come back to its original form. But by achieving an accurate match of the canal by pre-curving, you are ensuring that you're following the contours and anatomy of the root canal system. Controlling the amplitude of the stroke while filing, as a greater amplitude always leads to greater mismatch. This is exactly what I was trying to say in my previous video, that you have to control the amplitude. Otherwise, if you have a curvature like this in the apical third, and if you have huge amplitude strokes, you're definitely not going to go back into that apical third again and again every time you repeat the stroke. So let's have a look at different hand file motions which are necessary while establishing the glide path. I'm sorry, the audio is not available. So I'll try and guide you through the video as it progresses. So this is one of the techniques in addition to your regular watch winding, which will help you in working with curved canals. A balance forces technique where you pre-curve the K file and work around it, the root canal clockwise by a quarter turn, and then immediately maintaining the apical pressure, turn it around counterclockwise. So you turn the file in a counterclockwise direction by almost 270 degrees. So you've actually completed the full 360. Repeat the same motion of 90 degrees clockwise and 270 degrees counterclockwise, and maintain this motion. Repeat it 3 times over, and then withdraw it. When you do so, you will remove all the dentine debris that has been created by cutting of dentine using the balance forces technique. So this is how it would be conducted: a clockwise turn followed by a 270-degree counterclockwise turn. The regular watch winding always works while establishing the glide path. But in case of curved canals, you can always try the balance forces technique. I hope I'm clear. There's some noise coming from the flat above. I'm not able to do anything. I'm extremely sorry about that. Now we have established the glide path. Why can't we just go ahead with whatever we have established and not bother about the working length? Why is it important to establish the working length? So let us understand, why do we have to establish a working length and not just work with the glide path that we have established? Yeah, so the removal of all pulp tissue and necrotic material and microorganisms from the root canal is essential for endodontic success. And this can be achieved only if the length of the tooth and the length of the root canal are determined with accuracy. Why so? Because it is important for us not only to determine the working length, but also ensure that you limit your entire preparation, cleaning, obturation to well within the confines of the root canal system at the apical constriction. Now, long back in 1918, Dr. Custer had mentioned his observation, stating that the electrical method is based upon the difference in electrical conductivity of a dry pulp and pulp canal, or the one filled with non-conductive liquid, and the conductivity of the tissue just beyond the apical foramen, that is a pulp canal, and the contents being either a non-conductor or a poor conductor, will contrast very sharply with the normal conductivity of the tissue surrounding the apex of the root. So under proper electrical arrangement, we can detect an instant change when a broach, for instance, passes to the apical foramen, even much more quickly than when the patient tells us. So what basically did Dr. Custer observe way back in 1918, even before an electronic apex locator was introduced to dentistry? He observed that using the electrical method, one can locate the apical foramen in a much more precise and appropriate way, using the resistance of the tissues, which is a constant, be it the mucosal tissue or the periodontal membrane. So let us see how. So this is how it works. You have your electronic apex locator, you have engaged the lip clip, and you have the tooth, and this is the file which has been engaged on the file clip. So now you know that this is going to enter the root canal system, and your cementum and dentine act as insulators. The liquid which is present inside the canal provides the resistivity that is necessary. So when it moves into the root canal system, the cross-sectional area also keeps changing, and suddenly at the apical foramen, the file comes in contact with the periodontal ligament, and there is completion of the electrical circuit, and there is a beep in your electronic apex locator. Now, this is considered to be the most accurate method of locating, of determining the working length of the root canals that you're working on. Now, there is a big confusion over the root apex. When you take a radiograph, what you see, that is your radiographic apex. Now, the same tooth, if you were to examine, it has actually gone 2 millimeters beyond the apex. And what is this foramen? This is your physiologic apex. And this is actually where the tooth terminates morphologically. So this is your anatomic apex. So which apex should we follow as a guide for our working length? Well, it has to be our physiologic apex, because that is where the periodontal tissues come in contact with the pulpal tissues. So this is possible only when you use an electronic apex locator. So here's a small video which gives us an insight on how to use an electronic apex locator. What happened? Okay. It is important to know that apex locators or electronic apex locators, as they're called, are a must-have in your endodontic armamentarium. Let us try and understand how to use the apex locator. Every apex locator available is either a tabletop or a compact apex locator, which can be easily carried if you are consulting or if you have multiple clinics. So you have some details like the power, the volume. You can adjust all these variables to suit your convenience. Make sure that your apex locator is always fully charged. That's the battery, and this is how an apex locator functions. You always have the probe adapter, which is attached to the apex locator, and it has two ends. One is for the file clip and one is for the lip clip. So that's the lip clip. And the other one is the file clip. And now your apex locator is ready to use. Once you switch it on, make sure that it is fully charged or at least more than 50% charged. Do not use it when it is charging if you do not want errors. So this is a demo model where you know how to go about using an apex locator. So you place the file with a rubber stopper as you're establishing the working length. Once you have placed it up to resistance, you will engage the file clip on your file. Always make sure that there is no metal restoration or crown which will come in contact with your instruments. Also ensure that there is no liquid in the pulp chamber because it will lead to errors in your reading. It is okay to have fluid in the canals. Slightly move your file inside the root canal system in order to have good access and tactile sensation while you work with your apex locator. So place the lip clip on the opposite side of the tooth that is being treated. Insert a file with a snug fit, because unless it has a snug fit, it will not be able to sense the readings for you. Always use longer files so that there is sufficient place to place the file holder above the rubber stopper. So that's it. So when your file reaches the apex, you will get a reading, and this beep, as I explained to you, comes when the file reaches the apical foramen and then comes in contact with the periodontal tissues. So the resistance is constant in the oral tissues, and that is around 6 kilo ohms. And once the apex is reached, record it and set the stopper. Disengage the file holder, remove your apex locator, and confirm your working length with a radiograph in case you're not confident using your apex locator. It requires a little bit of practice and then you're good to go. Establishing working length with an apex locator has just been completed. So yes, what was I talking about? I was talking about my file reaching the apical foramen and coming in contact with the periodontal tissues. Now, what basically happens is it is important for us to know the anatomy, the microanatomy in the apical third. It is not as simple as it looks. It is not just a termination. There is an apical constriction. You have dentine there. You have cementum there. You have periodontal tissues. So how do we determine where to terminate your preparation? How to make sure that you are terminating your preparation at the narrowest diameter. Now, we can see a few markings here, anatomic markings. One is your apical constriction. It is that part of the root canal which has the narrowest diameter. The minor apical diameter is the diameter which is located 0.5 to 1 millimeter short of the apical foramen, and it widens apically into funnel shape. So you can see an inverted funnel here into a major apical diameter. So these are three terminologies. Now, the cemento-dentinal junction. So this is a cementum. The cementum is growing in, and that is your dentine. So as we age, there is continuous deposition of cementum, and the cementum goes further inside. So if we were to take, it's a histological landmark, and even if we were to take that as our actual termination, it wouldn't be practical because you cannot locate it unless you locate it histologically. Second, it would go way up into the root canal, so you can't get that kind of stop. So this histological landmark is not taken into consideration, and we stick to the apical constriction as our landmark for establishing the working length. The apical, now it's the point. Now it is the smallest point. So it is considered that it is going to create the smallest possible wound to the periapical tissue. So the healing is also much faster when you terminate at the apical constriction. There is histological evidence to confirm that optimal healing is obtained when there is minimal contact between root canal filling material and periapical tissues. So this apical constriction, when present, is the narrowest part of the root canal with the smallest diameter of blood supply and preparation to this point, and it results in a small wound site and optimal healing conditions, which is what we want when we perform root canal treatment. According to Ricucci and Langeland, the apical constriction is the narrowest part of the canal with the smallest diameter of blood supply, thus creating the smallest wound site and best healing conditions. So I've stressed it enough and more number of times that we have to terminate our preparation at the apical constriction, and we have to locate that when we work with our apex locator. Now we have found our working length, and now let us familiarize ourselves with the root canal system before going ahead with any kind of mechanical preparation or disinfection process. As Greek physician Hippocrates postulated, the anatomy is the foundation of medicine. Root canal anatomy is undoubtedly the foundation of endodontics. Guido Fischer presented the challenging nature of root canal anatomy for the first time to the world in 1907. The complexity and unpredictability of root canal morphology led him to coin the nowadays widely used term, the root canal system. So, all set to use the rotary instruments and modern endodontic armamentarium? Well, not yet. We still have to work with our hand files and familiarize ourselves with the root canal anatomy. Never ever ignore the role of hand files in our root canal preparation, because they play a vital role of locating the canal orifices, establishing the patency, negotiating the canals, creating a glide path, helping us to determine our working length, enlarging the body of the canal, recapitulation, bypassing a ledge, bypassing separated instruments, and in reading canal anatomy. So they are vital to our armamentarium in modern endodontics. So how do we choose instruments in modern endodontics? We are trying to be very precise when we work in root canals. We are working with magnification so that we can see what we are doing, and we are not working in a dark, small corner of the mouth. So if you are able to see with good illumination and with magnification tools, we obviously want instruments which are micro, which are smaller than what they were. Although the instruments that are being used are the same as what were used, they are much more smaller. They have long shanks so that we can visualize the area of work better. So our hand instruments will still be used. We will still extirpate tissues with barbed broaches and smooth broaches. We will still use rasps. We will still have reamers. We will still have files of all kinds. And depending upon our convenience, use the files wherever required, whenever required. So before moving any further, we have to slightly pre-flare the coronal thorns. Since we are not yet well acquainted with the micro preparation, and debridement is our priority, disinfection is our priority, because it gives assured results of healing. So orifice opening is nothing but pre-flaring. Now you have a canal here which is not pre-flared, and here which is pre-flared. What basically happens when you perform pre-flaring is you can insert larger hand files, which means that they would be visible in radiographs. So it helps you in confirming the working length. You can feel the tactile sensation directly at the apical third, and it will not get deflected from any of the walls. You can fill the entire canal with root canal with your irrigant solution. So while you're working with your files, the irrigant is also helping you clean up the canal systems. And then comes the engine-driven instruments. Now, once upon a time, we used to use gaze glidden drills for coronal flaring, but we are not using them anymore for coronal flaring. They only have a role to play when we have post-phase preparation and an instrument retrieval and in retreatment. Same with piezo reamers. Initially, they were used for post-phase preparation. Even today, we are using them for post-phase preparation. So they don't have a role in your conventional root canal, non-surgical root canal treatment. Now, the moment we use engine-driven instruments, we should know that there's something called as a gear ratio, and you cannot use the same handpiece, the micromotor handpiece, to run your rotary files, because your rotary files work at a certain torque and at a certain speed, which is much lesser than conventional. We have to bring down the speed, and hence it's called a reduction handpiece, bring down the speed, and hence it has a different gear ratio, 16:1. What is this gear ratio? It is a number of turns of the output shaft, which makes when the input shaft turns once. So if this turns once, this turns once. So for example, a gear set with a 1-inch drive gear and a 2-inch driven gear has a gear ratio of 2:1, means if this turns 2 times, this fellow will turn only once. And we have a reduction handpiece, which is 16:1. I hope I'm clear in trying to explain why we are cutting down the speed, because we're working inside a canal, and it is really that kind of speed that we have with a micromotor or an aerator is too much to use in a root canal, which is a narrow constricted space. We are sure to break our files inside the canal. So what are the instruments made of? The rotary instruments are made of nickel titanium. Why? Because they have amazing shape memory, super elasticity, low modulus of elasticity, resilience, corrosion resistance, and they're much softer than stainless steel. However, they have very poor cutting efficiency, and they do not show signs of fatigue and poor resistance to fracture. So what happened is that initial nickel titanium instruments were worked upon, and they're constantly being worked upon resistance to fracture and cyclic fatigue. So one thing they did with it, the manufacturers did with it, was they subjected them to thermal treatment to optimize their mechanical properties. We all know that nitinol has a crystalline microstructure. It exists in two forms, austenitic form and martensitic form. So the austenitic form is a rigid version and the martensitic form is a softer version. And when they're working in the canal, we want them to be softer, and we want them to conform to the root canal anatomy and quietly listen to what is happening inside. We don't want them to bounce back. We don't want them to restore themselves. So what to do? So they were subjected to heat treatment, and that heat treatment affects your crystalline microstructure and phase transformation properties. So these nitinol alloys configure in different temperatures, different structures. At higher temperatures, in an austenitic state, which is known to be that of a face-centered cubic, at lower temperatures, it exists in a martensitic crystalline structure, which is a monoclinic distorted structure. The distorted structure allows for the material to be deformed at greater angles. That's what we want. We want it to conform to the root canal anatomy. So this transformation between phases is initiated by inducing heat and stress. So you have these heat-treated files which exist at temperature. So when you're working them inside the root canal, they're actually conforming to the shape of the root canal anatomy while they are cutting. And examples, for example, we have the M wire, the R phase wire, the CM wire, etc. The CM wire is known for controlled memory, a proprietary thermomechanical process aimed to increase flexibility, reduce shape memory, and raise the transformation temperature. These heat-treated files were further worked upon, and you have modified versions because they're extremely soft and they conform to anatomy of the root canal system. You make them strong because they're there inside to cut. No, after all, they're not there just to flow there and then come out. They have to do their job of preparing the canal mechanically. So you have to reinforce them. So they were subjected to external treatment to reinforce them and make them stronger, resistant to fracture with improved resistance to fatigue as well. So the controlled memory wire was subjected to electric discharge machining, which gave rise to the EDM version of the same files. So how do you choose your rotary instruments? Now, considering that we have the facility to use magnification tools, we have premium illumination, we follow all the ergonomic essentials, and we are able to visualize our root canals well. Why don't we use rotary instruments which are equally conforming to modern endodontics? So why not use these heat-treated files which conform to the canal anatomy at body temperature? What is the advantage? Even if you were to go for a conservative cavity preparation, access cavity preparation, your files will still be able to be maneuvered and manipulated into the canal because they can be pre-bent and inserted into the root canal orifices with ease. One thing that I would like to recommend is whenever you work with a file system, choose a file system which is time tested, which is scientifically tested and approved, economical, and use a system which has minimum number of files so that there is no confusion, and it can be used in majority of the clinical conditions. So it's easy. If you buy a board of files, like a lot of file systems, each time you have to think which file system will I use for this case, and you're wasting a lot of time. Already, root canal treatment requires a lot of time, requires a lot of patience, and if it will require you to further plan it. But if you have one file system which fits in most of the cases, you have saved a lot of time and improved your efficiency at work. Achieving adequate apical preparations for disinfection without overflaring the coronal part is a huge achievement in highly curved canals. It's one of the greatest challenges in endodontic instruments, and all the kind of research that is being done is dedicated towards that. This is very true, especially under the current concepts of dentine preservation in endodontics. The heat-treated endodontic files play a major role in achieving that. So do pay attention to the heat-treated files which are available in the market. Familiarize yourselves with one system of files, understand their consistency, see how they can give you predictable results. If you understand the file system well, if you understand their design features well, if you understand their applications well, if you understand how the files move inside the canal system against the dentine, you will be able to handle it in most of the clinical conditions with predictable results. Now, when you work the file inside the root canal system, depending upon the clinician, either you will have an increased apical enlargement or you're one of those who's very conservative with your preparations. Now, if you were to go for an increased apical enlargement, you will have lesser debris and bacteria. Surface area will be cleaned much more. There'll be easier penetration of irrigants. It facilitates better fluid dynamics and better chemical disinfection. If you go for minimal apical enlargement, which can happen if you have an extremely curved canal, or if you are beginning with a sclerotic canal, then probably it retains more dentine, contributes to a stronger tooth structure, but you will have to do a lot of irrigation and disinfection to make sure that you ensure good healing. And also there'll be reduced chances of extrusion of sealers, and it is safer choice in limiting in anatomic limitations, as I mentioned. So there are no large and small apical sizes. They're just optimal preparations depending upon the clinical conditions that you're presented with based on biological principles. So that was a major phase in your root canal treatment. That was your mechanical preparation. Now, once you have prepared the canal, the major canals mechanically, you have to focus on the second most important part of your root canal treatment, that is irrigation. And that forms a major chunk of modern endodontics. Now, we were always mentally conditioned to preparing the canals with your files, irrigating it when you're preparing, because there is a shaping protocol. Every time you insert a rotary file into the root canal, you're going to insert irrigant inside the root canal, make sure it is well lubricated. You run the rotary instrument, withdraw the instrument, replenish the root canal with fresh irrigant, the irrigant of choice being 5.25% sodium hypochlorite. When it has been replenished, you will run a number 10K file into the root canal, agitate the liquid. Why? Because when you ran the rotary file, it has cut dentine and a lot of dentine has accumulated there. So you have to remove that. You have to auger it out. So that is done by recapitulating with a smaller hand file and patency filing by just running that file slightly across the apical foramen without moving it either clockwise or counterclockwise and withdrawing. This apical patency at the apical foramen area is just to disturb the debris which has settled apically. What happens is when you run a rotary file in the root canal, what happens? It cuts dentine and this debris gets accumulated on the flute, and it also accumulates in the in your apical third, and it settles down because it's kind of a stagnant zone. So you cannot afford to have your dentine debris accumulating in the apical third. You have to disturb it. You have to make sure that it comes out of your root canal system. And that is possible only if you disturb it with patency filing. And this has to be picked up and mastered because it helps you every single time you perform patency filing. So We have moved now towards irrigation. And now we will use the same irrigants which we were using during your root canal preparation, mechanical preparation, that is 5.25 sodium hypochlorite, but as an irrigant. What is irrigation? By definition, it is a process of washing out an organ or a wound with continuous flow of water or some medication. That is, you're flushing out debris. The same thing applies even in your root canal system. Why are you doing it? Because you want optimal spreading of irrigants throughout the root canal system for a more predictable cleaning of the difficult to reach areas, which constitute up to 40% of your root canal system. That's a sizable amount, which will help you ensure great results. Why to irrigate? There is residual organic tissue which is likely to weaken the quality of the seal by the permanent root canal filling. So, to sum it up, it is the use of chemical agents during instrumentation to completely clean the aspects of root canal system which is central to successful endodontic treatment. Irrigation is complementary to instrumentation in facilitating the removal of pulp tissue and microorganisms. So this point is very important. Why? Because when we are at our clinical practice, we are so conditioned to think because of the conventional endodontics that focus is on mechanical preparation and very little importance is given to irrigation, because irrigation and its focus is as much as mechanical preparation, probably much more. And this is possible only when you see what an irrigant can do to your canal system, which has been prepared once mechanically. So let us go through the slides in the presentation to understand how an irrigant can help you in further cleaning your root canal system. So first of all, what is the purpose of using an irrigant? An irrigant is used to rinse out the debris, to kill the microbes, and thereby to clean the canals which you have prepared mechanically. What exactly are you trying to debride? I mean, anyway, your files have prepared it mechanically, right? So what are you trying to debride? Well, as I told you at the very beginning, that root canal disease, the endodontic disease, is a biofilm mediated infection. You are battling the microflora and nothing else. And they will continue to exist in the form of biofilms, both in the planktonic form as well as biofilms, which will be accumulating in the smear layers. So you have two layers, the top layer and bottom layer, both of them which are equally toxic. It's an aggregate of slowly growing bacteria which is embedded in extracellular polymeric substance polysaccharides. So it's an aggregate, and there are so many bacterial colonies accumulating there. So you have to deal with all of them. And they're embedded in your smear layer, which is made up of organic and inorganic components, which means your irrigants have to deal with all this when they work inside the root canal system. And hence, we have to perform dedicated irrigation after your mechanical preparation, or in addition to the irrigation which happens during your mechanical preparation. Irrigants always have multiple functions. They should be good lubricants, they should be good disinfectants, and they should be good chelating agents. So let us have a look at these irrigants and find out what they do. Now, when you irrigate a root canal, it is always a syringe and a needle which is used. Conventionally, we used to use a regular open-ended needle and a syringe to irrigate the root canal. These needles were pretty broad and they would never reach the apical third. But now, as we have gone micro, we have understood that unless we reach the apical third and deal with the bacteria and microflora present apically, you cannot assure a good apical seal or good healing. So you have to use needles which are close-ended, which are side-vented, so that even if your needle moves into the apical third, it will not dispense the irrigant beyond the apical foramen, because using the strength of irrigation material like 5.25% sodium hypochlorite, which is extremely caustic, can be extremely harmful to the tissues if they go beyond. So you will use a closed-ended needle which is side-vented, which moves passively into the apical thirds of the root canal, and you will dispense the irrigant without wedging or forcing the needle. So avoid extruding it beyond the root canal foramen. This is your passive irrigation. So you have dispensed it and you're just waiting for the irrigant to work. You're not doing anything. It is just the chemical properties of the irrigant. It is just the temperature and the friction it creates which will enable passive irrigation. What is active irrigation? Now, one thing we can do is just dispense the irrigant and sit. And the other thing that we can do is perform active irrigation. Active irrigation is dispensing the irrigant in the apical third, filling up the pulp chamber, and activating the irrigant by agitating it. So how do we agitate the irrigant? Using your instruments like sonic and ultrasonic tips, or even if you have none of them, by manual dynamic activation. So what exactly happens when you efficiently, effectively disinfect your canals? You will find something as clean as that, both in the bulk chamber as well as in your root canal system. So what is this activation? Machine and manually assisted irrigation technique. This is a technique wherein you agitate the irrigant and constantly refresh it, greatly improving the effectiveness of the solutions. So let's have a look at manual dynamic activation, because this is something which you can do right away from tomorrow in your clinical practice. You have already prepared the canal, so you know the dimensions of your final apical file. So all you have to do is choose your master gutta percha cone, which has an excellent frictional fit in the apical third. Why am I focusing on the apical third? Is because this is the place where you have the entire major chunk of microflora sitting there with very low oxygen concentrations, and it becomes a seat of all the trouble that is to come if we do not effectively clean it. So if the apical canal cannot be easily reached by the irrigation needle, a gutta percha point and size corresponding to the dimensions of a apical canal can be used to facilitate irrigant exchange in this region. So what are the instruments which you will be using to activate and agitate the irrigant, say 5.25% sodium hypochlorite or your EDTA? It can be both sonic as well as ultrasonic instruments. Now, sonics are milder. They produce a frequency of less than 20 kilohertz, some of them close to just 1. And there are ultrasonics, which have very high frequency of 40 kilohertz and above. Sonics uses compressed air and ultrasonics uses electric current. So what is this activation and agitation? So whenever you activate an instrument, it is always passive. You do not allow the instrument to come in contact with the walls of the canal. So it is passive ultrasonic irrigation, which is the most preferred method of activation of root canal system, because it is easy, it is economical, and it is also easily available. It has some advantages. What does ultrasonic activation do? So when you place an irrigant like 5.25% sodium hypochlorite in your root canal, reaching up to the apical third, and place an ultrasonic file, endodontic file, inside passively and activate it, it basically agitates the fluid. It's all about hydrodynamics. The fluid is moving in all the directions, getting agitated, coming in contact with all the areas of the root canal system under pressure. And it also dissolves everything because the temperature is also increasing. You know, ultrasonics produces a lot of heat. So this increase in the movement produces bubbles, and these bubbles tend to get larger and larger and implode. That mechanism is called cavitation. And when it implodes, there is further movement of liquid inside the canal. And this is called the acoustic streaming effect, which increases the wall shear stress and enhances the rupturing of intraradicular biofilm, which is one of the main reasons it is a preferred method of agitating the root canal system. The passive ultrasonic irrigation also has some drawbacks. First of all, the contact of the file with the root canal wall dampens the energy of the oscillating instrument and constrains your file movement. So it is very difficult to activate in curved canals. And also, if you have very sclerotic canals, which you're prepared with great difficulty, and if you do not have a ultrasonic tip, which can stay passive inside that canal, you cannot get the same results. Then you have to consider sonic devices, which are present. They do have some advantages, like the oscillating points are made of a plastic material like polyamide. So there is no risk of breaking it, whereas your ultrasonic tips are stainless steel, and there's a good chance that if you're a bit careless or if there's a lapse in concentration, it could come in contact with the walls and easily break. It does not stop when it is in contact with the root canal wall, and it is not able to deform the root canal wall like what an ultrasonic can do. So it can be used safely even in curved canals. So that is the way you should be able to use your sonics and ultrasonic instruments aptly in irrigating and effectively disinfecting your root canal system. Now, what, as I said, most importantly is that the activation tip should not bind. If it binds, we do not benefit from the hydrodynamic effects of irrigation. What and how do you look for an irrigant? We want something which is low cost, which has excellent washing action, which has a reduction of friction, improves the cutting of dentine when you're using it along with instruments, and which has excellent temperature control, dissolution of organic and inorganic matter, good penetration of dentine in the root canal system, killing of planktonic as well as biofilm microbes. Planktonic is the microbes which are floating in the canal, and the biofilm ones are those which are attached to the smear layer. So it should work on both of them. It should facilitate detachment of the biofilm. It should be non-toxic to the periapical tissues and not allergenic. And it does not react with the negative consequences with other dental materials. That is equally important. And above all, it should not weaken dentine, because after all, we are trying to make this tooth functional. So the single most popular irrigant which conforms to most of this is your sodium hypochlorite solution. Sodium hypochlorite is used in varied concentrations, right from 0.5% to 5.25%. And when it comes to disinfection of root canal system, 5.25% is extremely effective, antibacterial, very effective in dissolution of organic matter. However, it does not have a chelating effect. The other drawback is it's extremely caustic, and for some reason, if it crosses your apical foramen, it can lead to major systemic damage. That about sodium hypochlorite, it still continues to be the single most commonly used irrigant for disinfection as well as during the shaping protocol. Now, since it does not have a chelating effect, we have to look for something which is a good chelator, and that is when EDTA comes into picture. EDTA only affects the inorganic part of the dentine and smear layer, and complete removal of the smear layer can only be achieved when sodium hypochlorite can be used before the final rinse with EDTA. So that is basically your EDTA removes the smear layer, opens the dentinal tubules, and then you use sodium hypochlorite in high concentrations so that the sodium hypochlorite is able to penetrate the dentinal tubules and eliminate the microflora as much as you can. Because our goal is to reduce the microflora, not completely eliminate it, as it is not possible humanly at this point of time. Using citric acid, if you do not have EDTA, you can always use citric acid as a final rinse to remove the smear layer after use of sodium hypochlorite. 1 to 10% solution has been used, and citric acid is somewhat more aggressive than EDTA. And if sodium hypochlorite is used after citric acid, it is not recommended, as a root canal wall erosion is more pronounced than in a combination of EDTA and sodium hypochlorite sequence. It is also used as a component in MTAD and tetracline, which are combination products used for smear layer removal. Chlorhexidine digluconate is used in dentistry for plaque prevention and disinfection because of its good antimicrobial activity. It has also been much used in endodontics as a final irrigant after EDTA. However, it hasn't gained much popularity in modern endodontics because it has only one function, that is, it kills planktonic bacteria, but it is much slower than sodium hypochlorite. And against bacteria, biofilm bacteria, its effect is equal or lower than that of 1 to 2% sodium hypochlorite. Suppose we are using 5.25% of sodium hypochlorite, we have supreme efficiency. So why incorporate one more irrigant like chlorhexidine? So that's the reason chlorhexidine has been losing its popularity as an effective antibacterial irrigant. And sodium hypochlorite still stands strong as a recommended irrigant for effective disinfection of the root canal system. Now, coming to the apical area of the root canal once again, if you notice, every time, wherever I go, I always come back to dealing with the apical area of the root canal system, where the oxygen tension is the lowest and predominance of anaerobic bacteria is even greater in the main canal. Now, what happens is, from the root canal, the bacteria enter tubules of root dentine, which means your root canal infection is everywhere, in your main canal, in your lateral canals, apical deltas, as well as infection of root dentine. So unless and until you have something which reaches here and effectively disinfects it, you're not really confident about effective disinfection of the whole system. Irrigation is the only way to impact those areas, obviously. And that too, you have to use a combination of irrigants. What are the functions? The irrigants have to work mechanically, chemically as well as biologically. As I told you, they have to be good lubricants. There has to be irrigants which are good chelating agents, and there have to be irrigants which are great disinfectants and antibacterial agents. Now, coming to one of the techniques of irrigation, just like I told you that we have passive irrigation and active irrigation, there is something called as negative pressure irrigation, positive pressure irrigation. So let's quickly have a look at what is this and why is it so important in our irrigation protocols. Negative pressure irrigation was introduced to endodontic treatment several years ago as a safe method to effectively irrigate the most apical canals. Now, we are talking about reaching the apical third, and we have to have syringes which reach the apical third. Assuming that you have prepared your canal apically to a size 25 or 30, you need a gauge of at least 30 to reach that part of your root canal. So here is your positive pressure irrigation and negative pressure irrigation. Now, both these have the same kind of tools. You have one needle which is placed right up to the apical third and one needle which is in the coronal third. The same scenario here. However, in the positive pressure irrigation, the irrigant is being introduced in the longer needle and it is rapidly being aspirated by the shorter needle. So this is one method where you're creating the agitation. And the second method is where you're introducing the irrigant through the shorter needle from the coronal thirds, and it is being rapidly sucked in by the longer needle present at the apical third. So imagine the negative pressure irrigation wherein the irrigant is forced to the apical third because of the suction created by this needle, and then it is being aspirated into the needle. So it is put under pressure, it hits the walls under pressure, and even before it touches the apical foramen, it is rapidly being absorbed, aspirated into the needle. So basically, it ensures greater effective cleaning in the apical third area, which happens to be the single most important reason for us to be irrigating and disinfecting. The apical vapor lock and its significance. Now, it so happens that when you insert the needle of appropriate quality, that is a closed-ended needle, which is side-vented, it goes way down into the apical third because you have chosen a 30 gauge needle. Good. The sodium hypochlorite is introduced. The sodium hypochlorite in high concentration of 5.25% will come across organic components. It will react. It will release ammonia and carbon dioxide. It is the hypochlorous acid, which is the chlorine, the free chlorine, which is the active component of your sodium hypochlorite irrigant. So they have reacted and they have released ammonia and carbon dioxide. So these are gases. So obviously bubbles will be released. And this is what creates a vapor lock in the apical third. And that ensures that anything which is below the vapor lock is stagnant and anything above that is the only part which is mobile or which is in circulation. So how to break this vapor lock? It can be done only by manual dynamic irrigation or negative pressure, manual dynamic agitation or negative pressure irrigation. And hence it is important for us either to have a gadget like EndoVac, which works on a concept of negative pressure irrigation, or to master the skill of manual dynamic agitation. So apical irrigation definitely poses a special challenge with regards to effectiveness and safety. So these are the two important things you have to consider when you're working with apical irrigation. Now, we are spending so much time because we are using sodium hypochlorite and EDTA alternately for a period of 1 minute and activating it and doing this for each and every canal for a specific period of time. So it takes nearly half an hour to 45 minutes to complete this process of irrigation. And all this while you are working patiently, obviously because you want good results, it's your job. But what about the patient who's keeping the mouth open for such a long period of time? Quite naturally, as a clinician, you're always thinking about your patient convenience, patient safety. So you will consider products which are combination products meant for irrigation, which will do the same job, which is performed by sodium hypochlorite as well as your EDTA. So they include sodium hypochlorite, which is mixed with a surfactant, or an EDTA or citric acid, which is mixed with surfactants and or antibacterial agents. So they will do the same thing in a reduced period of time. So you will be able to complete the process of irrigation and disinfection in a much shorter period of time, enabling patient compliance. The use of combination products should simplify irrigation and also eliminate the need to use final sodium hypochlorite rinse after EDTA because there's a risk of erosion of the dentine walls. So the impact of irrigants, medicaments, as well as restorative procedures and even physiological age changes should also be taken into account whenever you're performing the disinfection. Root canal therapy requires effective shaping in order to facilitate your irrigation and disinfection. This should be done in a very conservative manner so that the structural integrity of the tooth is always respected and dentine is preserved wherever possible. So I think I'm making it very clear that modern endodontics is all about effective disinfection, effective obturation, effective dentine preservation, and maintaining the structural integrity of the tooth. So these are the main goals of modern endodontics. While we are doing so, we also realize that there is no single irrigant which has all the properties of irrigation protocol. So we have to follow a protocol wherein you have a shaping protocol where every time you're filing the root canal, you'll fill the canal with 5.25% sodium hypochlorite solution. You will make sure that you will use a number 10K file with a fresh dose of sodium hypochlorite, agitate the irrigant and recapitulate it. Perform patency filing at the apical foramen, come back, introduce a fresh dose of irrigant and go back with the next set of rotary files. So that is your shaping protocol and the final irrigation protocol where you will use alternately sodium hypochlorite and a chelatic agent like EDTA or citric acid, which will help you in removing the smear layer and use the sodium hypochlorite to effectively penetrate the root canal dentine to disinfect the root canal system. So that is your ultimate goal, that is disinfection of the root canal system. Now you have done it, your canal is ready for obturation. However, unless and until you have taken an X-ray to confirm your master cone, which is selected, which fits appropriately both to working length as well as gives you a great frictional fit, that is your working width, you will not go any ahead. So once that is confirmed, you can consider the process of obturation. So the purpose of
Pavana, how much is left?
Obturation will take 10 minutes probably.
That will end your presentation, right?
Yes, exactly. We have gone too long.
Okay. Yeah, we have actually crossed 1 hour extra. No problem. Proceed.
Okay. Because it's a very vast topic. I'm extremely sorry if I've bored you.
Yeah, no problem. Yeah, please proceed. Thank you.
Yes. So the obturation. Now we have done whatever has to be done. All we have to do is we have to endome the remaining bacteria and seal the root canal system well, both from the apical end and from the coronal end. So the first step is to seal it from the apical end. And always remember that a perfect appearance of a root canal filling on a radiograph is no proof or predictive value about the sealing efficacy of your obturation. Remember that your goal of obturation is to seal all portals of re-entry of microorganisms into the system and prevent provision of nutrients to the remnant bacteria in the clean canals. What is important is knowing when to obturate. First of all, the patient should be asymptomatic, no pain, no swelling, no exudate in the canal, a thoroughly divided system, as well as having adequate time to complete the procedure. Considering that you have taken so much effort to sit together and complete the tasks, all the protocols systematically, if you were to do your obturation in a hurry, you'll compromise the final step. So it's important that you have sufficient time to complete the same. Ideal outcome would mean periapical healing, regeneration of the periodontal ligament, and sealing of the apical foramina and laying down of cementum. And you will definitely see this if you follow all the protocols religiously. When it comes to obturation, you know very well that obturation consists of two components, namely the obturation material and a sealer. And we have been very well acquainted with the requirements of an obturation material with the properties introduced by Grossman and ideal properties of a sealer. In short, an obturation material forms a major component of your obturation. It is rigid or semi-rigid, and your sealer just flows into all the finer details where your core material cannot come in contact with the dentinal walls, and hence it helps in creating an excellent seal. So sealers are a very necessary part of the obturation process because they fill in the gaps between the dentinal walls and core root filling materials, as well as a space between the core segments if applicable. So they are of different types: zinc oxide sealers, calcium hydroxide, resin-based bioceramic sealers, which are amazing because they have all those properties which other sealers used to lack previously. They have very good biocompatibility, excellent antimicrobial properties, regenerative properties, and they do not shrink when they set, and they have excellent working time too. So the core material generally preferred is gutta percha because it works in most of the conditions because of its excellent properties of radiopacity, ease of manipulation, ease of removal, etc. And of course, its plasticity. We use both alpha and beta versions of gutta percha. So modern endodontics is about three-dimensional obturation, and therefore alpha gutta percha in its thermoplastic state has taken a great lead or occupied the field of obturation, I should say. So any method of heating gutta percha will result in 1 to 2% shrinkage of the core material. This is what you have to remember. Although you're doing great obturation, every time it cools down, it shrinks. So you will see discrepancies and you will not know why it is happening. So remember that every time gutta percha is heated, it will also shrink. Exposure to air and light will cause gutta percha to become brittle. So you have to always store it in a cool temperature. So simple, we always prefer lateral compaction, which is very easy for any clinician to execute. It all consists of choosing a master cone, which has an excellent frictional fit in the apical third, and all the other empty space, which is left behind by the master cone, is filled with lateral cones, that is your bilateral condensation. So what is important to know about lateral compaction is that the set of GP points, gutta percha points, which have been compacted along with the master cone, have not formed a single condensed unit. Rather, they've been compacted together to fill in the gaps. And of course, the sealer flows into all the rest of the gaps. So it is definitely a good option in regular clinical practice. But what is most preferred is warm vertical compaction, wherein you're using down pack and backfill methods of obturation. You place the master cone and you down pack it to 4 to 5 millimeters of the apical part of the canal. So when you down pack it consistently by applying heat and removing excess gutta percha and plugging it with finger pluggers, you have compacted it very well to adapt the walls of apical third of the canal. And then you backfill the rest of it with your thermoplasticized gutta percha and seal it up till the coronal orifice. So every time you're plugging in, you're filling in gutta percha, you're plugging it with finger pluggers and ensuring that it has excellent flow. Warm lateral compaction. A master cone corresponding to working length and canal shape is coated with sealer and inserted. Instead of using a regular spreader, you're using a warm spreader so that heat compacts the core in a much better manner. So that is the only difference in warm lateral. Then there is a carrier-based thermoplasticized technique. So in this, what happens is instead of using a gutta percha, you're using a plastic core which is coated with gutta percha, or you're using a gutta core coated with gutta percha. What happens? It is placed in an oven and heated, and then after slightly coating the canal with a sealer, you're introducing this into the canal. So when you place it with force, it ensures a great flow of the thermoplasticized material into the finer details and ensures an efficient three-dimensional filling. Then the apical barrier technique. Now, when you have blunderbuss canals, you can't obviously follow traditional methods. You have to first create an apical barrier with MTA, which is up to 4 to 5 millimeters, and then backfill the rest of the canal. So it's very important to maintain your working length, very important to do a cone fit, radiograph before you proceed with obturation. And if it is not sealing well, you have to find out why before you obturate. Do not blindly go ahead with an obturation. Take your time, take repeated radiographs at repeated steps. Sometimes canals are coalescent, then only one canal will have GP going to full working length and the other one will have to be trimmed and abutted to the other gutta percha. So all these things have to be taken care of. The most commonly used method and preferred method of obturation now, because of the properties of bioceramic-based root canal sealers, is the hydraulic condensation with single cone. Bioceramic sealers have excellent properties of biocompatibility, sealing ability, adhesion, solubility, and antibacterial efficiency, which is why a single cone method where the canal is coated with a bioceramic sealer and the master cone is placed is preferred, as it saves a lot of time and also because sealer has excellent properties. So when we perform obturation, it is all about having sufficient time, correct armamentarium, and operator skills to give a great conclusion to all the efforts of root canal cleaning and shaping and disinfection that you have performed. Being persistent may lead you to the door, but being consistent is the key which unlocks it. Thank you very much for your kind attention. I'm open to questions and I'm extremely sorry and apologetic for taking a lot of your time. But root canal treatment is such a vast topic that it cannot but take at least this much time to cover this in the smallest way possible, shortest way possible. I'm open to questions.
There are a lot of questions in chat box.
Yeah.
Like first is by Dr. Jean Muri. Why are accessory canals mostly present in the apical third?
That is anatomy. I have no control over it.
And the second one is by Dr. Lavanya, I guess. She's initially, can we use rotary glide path file instead of hand files?
Rotary glide path, definitely. We can use rotary glide path files instead of hand files, provided you have the skill and expertise to use it, because glide path is a very delicate step. And as I said, slight lapse of attention can make you lose several millimeters of the apical third, which is the most crucial part of your root canal. So if you have the necessary skills, you can definitely go for it. There is no problem at all.
Dr. Neeraj has had a question, Pavana. Can we use 3% sodium hypochlorite for the irrigation? That is his question.
Yes, definitely we can use 3% sodium hypochlorite for your irrigation protocol as well as for your shaping protocol. The only thing is, if you bring down the concentration of the irrigant, you have to always use greater volume of the irrigant to make up for it. So you have to frequently keep replenishing it. You use it and then replenish it with more doses of sodium hypochlorite. Volume increases.
Okay. The another question from Neeraj is how to decide which cases to be taken for a single sitting or a multiple sitting?
Quite simple. It's not quite simple, actually. If you do not have an abscess, if there isn't any necrotic changes in the pulp, which of course comes at the very first stage of your diagnosis when you perform your vitality test and when you do your clinical examination. If you have a huge swelling or if you have an abscess inside, definitely don't take it up for single visit. But yes, if you have a vital pulp, if you have like a pulp polyp, all these cases are good for single visits. If you have a draining fistula, also you can consider, because you can, there is a passage. So even if you manage to isolate it well and perform your entire procedure with aseptic technique and you're able to irrigate and disinfect well, that fistula will also resolve.
Right. The next question from Shashank is, how can we use sonic irrigation in maxillary molars?
Why not? First of all, we have to consider this, that whether we are working on maxillary or mandibular, if you are planning to use a good irrigation protocol, if you're planning to follow all the steps, you have to first begin with rubber dam isolation. So when you have isolated, you've isolated only a single tooth and nothing else is exposed. You have to dispense your irrigant. You're dispensing the irrigant with your 40 gauge needle, which means that it is going right up to the apical third. And when you're activating your sonic or ultrasonic, it is well within your canal, at least up to the middle third and at the junction of the middle third and the apical third. So why not? And it's all about smartly placing. See, it's basically how the operator orients the working hand. So you can change your position. You can be at your 9 o'clock position, 10 o'clock position, 12 o'clock position. So some things, like for example, your parietal canal can be easily done so with your 12 o'clock position. But maybe for your mesiobuccal, you'll have to move towards the 9 o'clock position. So it becomes easy for the operator to place a sonic file, the sonic tip inside.
Okay. That's wonderful. There is one one question is interesting from a BDS student, Vaitarini Garg. Madam, what is the difference between the irrigation protocol for vital and non-vital root canal treatment?
Very nice question, and I'm very happy to hear it from your student. See, what happens in a vital pulp? You have a lot of pulp tissue. What happens in a necrotic pulp? You have a lot of necrotic debris. I did highlight this at the very beginning of the presentation when I told you, what will you find in vital pulp? What will you find? What are you dealing with? Either you're finding an inflamed fibrous, inflamed pulp tissue, or everything is dead, everything is necrotic, and there's a lot of bacteria inside, isn't it? So when you have pulp, and if you use sodium hypochlorite as a first irrigant, the whole thing will turn reddish, brownish, and everything will get obliterated. So there what you have to do is you have to carefully use EDTA, extirpate the pulp tissue, and then continue with sodium hypochlorite. In case of necrotic pulp, there is only necrotic debris. You won't find a pulp tissue. So you have to begin directly with 5.25% sodium hypochlorite right from the time you have accessed the pulp chamber. So the moment you put it, it will clear up the entire floor of the pulp chamber for you. Then you introduce it into your root canal orifices. And again, it will help you with your glide path as well as your working length and even your shaping protocols along with irrigation. I hope I have answered your question, addressed your question well.
I will just go with the last question, although there is a lot of questions are there. One, Dr. Yasha Yadav has asked question. Ma'am, what was the difficulty during obturation plugging in truss preparation as there is no enough space in access?
As there is no
enough space in
yes,
access.
Exactly. And I highlighted this even in my next slide. If you have noted, I said that the problem with minimal access openings is that you have very little visibility and access. So, and there's still a lot of study being done because, you know, unless and until you have a certain level of skill and expertise, you shouldn't even be considering attempting it because everything is happening within small enclosed spaces. And the biggest question is how will you effectively clean the pulp chamber if you have the truss, the dentine in between? So, you know, there's so many factors which need to be addressed very scientifically and proved. And until and unless that is done, we will always have these questions coming.
Let me take a last question from same Dr. Yasha Yadav. What would be the irrigation protocol in retreatment cases?
Yes, in retreatment cases, what are you dealing with? You're dealing with infection. So you're dealing with a lot of necrotic debris. You're dealing with a lot of, if you have silver points, you're dealing with corrosion products. So, you know, you have all these things. So you have to use plenty of sodium hypochlorite, plenty of saline in the very beginning. And then as you enter the canal system, you'll be using a lot of sodium hypochlorite to clear the necrotic debris, which is the consequence or which is responsible for the infection, which has led to retreatment. So yes, you have to focus a lot on irrigation when you're working on a retreatment case.
Thank you very much. I know the endodontic doubts are not never-ending doubts, and I request you to at least share your email or your number so that anybody here would like to communicate to you directly, so that it will be easier for the communication. And that's will then from a moderation point of view, I am like, you know, ending this here.
Yes,
and
I'm sending my email ID so that if anybody has queries, they can always ask me. And even those questions which remain unaddressed, I'll be happy to answer them and share it with Dr. Manjunath or whoever would take charge of dealing with the questions for the attendees. So please make them available to me, Dr. Manjunath. I will definitely answer all of them. And thank you very much. There's a wonderful certificate I can see being presented to me. Please continue.
I hand over the next the time to the Dr. Rahul Vora, our one of the senior practitioner, most energetic practitioner, and I just hand over the time to Dr. Rahul Vora.
Thank you, sir.
Yeah.
Good afternoon, Dr. Pavana. It was a tremendous lecture, I must say. I've heard a lot of endo lectures, and I'll say that coming from the land of great South Chhatrapati Shivaji Maharaj, you have like just blasted us all away. And it is one lecture I was not feeling sleepy and groggy at all, even after a quarter to 2 hours of long lecture and deliberations. And one of the most elaborately and simplified endodontic lecture I've ever heard since a long time. So thank you so much.
Thank you.
And to surprise you a little bit, I have just say thanks in your language that आज दिलेल्या मौल्यवान वेळेला आणि ज्ञानाबद्दल तुमचे आभार मानू इच्छितो. So I hope you'll forget my pronunciation. And to all those people who are listening, I just thank Dr. Pavana in her native language in Marathi. And I have studied in Bharati Vidyaput Pune, ma'am, so I can correlate a little bit of Marathi, sir. More or less the same batch, 1992 batch.
Fantastic.
Yeah, so it was great to have you. And We are extremely thankful, and to you, Dr. Manjunath sir, and to all our listeners who spend their valuable Sunday time devoting to endodontics, and right from the beginning to the preparation of the cavity, access cavity opening, sonics, ultrasonics, irrigation protocols, obturation. You covered everything in a very, very condensed and fantastic way, not making it boring at all. And I'm sure the entire gathering who attended this lecture will have huge benefits in their practice once they implement it. Thank you so much, ma'am.
Thank you. Thank you very much. Thank you.
With that, we'll come to end of the program. Pavana, you will receive this certificate personally to your address. I would like to kindly share your address to my WhatsApp later, and we'll do that. And from personally, I'm extremely thankful to you for sparing your so much of valuable time. And I know how much busy you are in your practice, how much your schedules are so tight. In spite of that, you never said anything, negatively with that. You just straight away accepted the invitations. And from the IDA Bareilly family, I'm extremely thankful to you and looking
Thank you
forward
very
to being
much.
connected with you in the future also. Thank you
Thank
very
you.
much, and thanks to all the IDA family from Bareilly for your valuable time today, Sunday. You have come and 2 hours you spent here. Thanks a lot. Thank you, Pavana.
Yes.
Thank you once again, ma'am.
Bye.